Assalamu alaikum, everyone. My name is Mujeeb Shad, and I work in Las Vegas, but I don't gamble. Uh, so that's a good thing to be in Las Vegas and still enjoy the shows and without losing money, right? So I am a residency program director at the Valley Health System in Las Vegas, and we are starting a new program this next year. I'm also affiliated with the University of Nevada, Las Vegas, as well as I'm also an adjunct professor at the Toro University, Nevada College of Osteopathic Medicine. It is also in Las Vegas. So the title of my presentation today is, I think it's quite interesting because over the last couple of decades, there has been some explosive growth in psychopharmacological knowledge, and we have found some really novel mechanism of actions and new molecules to treat disorders which are not even full diagnostic illnesses in DSM-5, and now we are treating some of the symptoms, the side effects of the long-term use of medications in psychiatric patients, as well as we are also have approved molecules to treat relatively not so common conditions, but with a minor role in psychiatric practice. So we are going to very quickly go over all those things. So let's go to the next slide. Yeah. So my aims and objective is primarily to update you on some of the recently approved psychopharmacological agents by the FDA here in America for major as well as minor psychiatric indications, as I discussed earlier. So this presentation is not a review of efficacy or tolerability of psychotropic medications, because I don't have time for that. But if I can introduce you to some of the exciting molecules and new treatments, I think that is the main goal of this presentation. So some of the new psychotropics, relatively new, because some of them have been approved several years back. But I just wanted to mention them. I don't have time to discuss everything, but some of the new antidepressants are very exciting, including the most exciting discovery in decades in the treatment of depression, as you all would know, is the esketamine, the intranasal esketamine, which is approved by the FDA for the treatment of refractory depression. And then esketamine is followed by vertioxetine. And vertioxetine, I'm going to discuss a little bit more in detail, a couple of minutes maybe, because it's kind of a relatively different molecule in the treatment of depression. And I'll tell you later why. There is a serotonin norepinephrine reuptake inhibitor, new one, relatively recently approved. It's called levomilnacipran. And that is something which I will briefly touch on. But another very exciting molecule which got approved for the treatment of postpartum depression for the first time ever in our history is brexanolone. And I will discuss a little bit about that molecule, because as we all know, postpartum depression is a psychiatric and medical emergency. And approval of a treatment, which is actually in some ways like esketamine, has a relatively faster onset of action, because you need that. A patient comes to the ER with postpartum depression or is in the hospital, you need to immediately address the postpartum depression and the psychosis which is related with it. So this is another exciting molecule. Then some of the new antipsychotic medications, they are old, but their formulations have been are different. Their delivery systems are different, and a couple of them, brexpiprazole and cariprazine are actually were approved many years, some few years back, but they are new. But Aristada is aripiprazole formulation, and risperidone, of course, everybody knows that they had another long-acting injectable approved for it a few years back, which is 1 monthly, as compared to Risperdal Consta, which is once every 2 weeks. And then there is a new non-stimulant medication approved for ADHD, which is viloxazone, and the trade name is Quellbri. And there are some exciting sleeping aids targeting a completely novel mechanism of action, which is blocking the orexin receptors, and some of them are here. But Rimeltion is actually modifies the melatonin effects along with a subtype of serotonin receptor blockade. So that is different, but Suvorexant and Lemborexant are the ones which are the blockers for orexin receptors. Won't have time to discuss them, but just wanted to mention if you want to read about them. Then there are some new indications which were never existing before. Quite exciting development in psychopharmacology. Actually, this is a very short time to discuss all these things. I wish I had more time. But just to mention, because I won't be able to elaborate on these in detail, I'll touch on a couple of them at least. One is pimavanserin, which is 5-HT2A, which is the subtype of serotonin receptor. It blocks 5-HT2A receptor, and it was approved by the FDA for the treatment of Parkinson's psychosis. Quite an exciting discovery, because, as you all know, treatment of Parkinson's psychosis with antipsychotic medications which are antidopaminergic has been very difficult because of the worsening effects on Parkinson's because of the dopamine blockade. Then you have the medication which, again, I told you already about it, brexanolone for postpartum depression. And then there are a couple of medications, very exciting discovery in treating tardive dyskinesia, which is the side effect from the long-term and high-dose use of antipsychotic medications. One is valbenazine, and the other one is deutetrabenazine. If we have time, I'll slightly elaborate on those. And then there is a hyperactive sexual desire disorder in females, and a drug got approved for that, which is flibanserin. But I don't know how much impact it can make because it is not as effective. It's not cost effective, in other words. And then last but not the least is a very exciting molecule, which was, we already knew this molecule for decades. It's called dextromethorphan. Some of you might remember from antitussive syrups, because it is a opioid-like agent and opioid molecule, and has been frequently used for the cough in the cough syrups. But this is in combination with the quinidine, and the trade name is New Dextra. And this drug is, I would like to talk a little bit about it at the end, but this is the first drug to be approved for pseudobulbar affect. So let's talk about the ketamine, because, you know, this is one of the most exciting discoveries which we have seen in decades, since mid-50s, when tricyclic antidepressants and monoamine oxidase inhibitors as the first effective treatment for depression were discovered. So ketamine is a NMDA receptor blocker, and NMDA receptors is one of 3 ionotropic receptors from the glutamate system. So this is a glutamatergic receptor, which is called NMDA. So ketamine blocks NMDA receptor. It has some other effects as well. It has effect on sigmoid receptors. It has effect on mu-opioid receptors, and it also has some effect on serotonin and norepinephrine reuptake pump. The action of ketamine can be really described well based on the model of a cartoon using an ion channel, because an NMDA receptor is an ionotropic receptor. When the ligand binds to the channel, it changes the lumen of the channel, so that if there is an antagonist at this site, it will close the channel, and very few electrolytes can pass through. But if it is an agonist, then we open the channel more so that more electrolytes can pass through. And what ketamine does is that it actually opens up the channel at the one of the sites in the NMDA receptor, and this site is also known as the PCP site. If you remember, PCP stands for phencyclidine, and phencyclidine is one of the most potent inhibitors of NMDA receptor, and it actually provides the best pharmacological model of schizophrenia, better than stimulants, because it can actually result in a syndromic picture of schizophrenia, including negative symptoms, positive symptoms, as well as cognitive symptoms. So this side is important. So what ketamine does is, ketamine is not as potent as phencyclidine, but it does open up this channel at least partially as compared to phencyclidine. And so you see in this cartoon that when ketamine binds to this site, the electrolytes pass through, and so that's the ketamine, which is actually is shown here. Again, so the ketamine. So the ketamine was synthesized in 1962, and it was first used in humans in 1965. So this is not a new agent. Its availability, if you take it orally, is very, very minimal, and it only 20% of the drug is available if taken orally. That is why people have to use infusions, and the S-ketamine is approved as an intranasal administration rather than taking orally. This is another model of AMPA receptor mechanism. Ketamine's mechanism of action. Basically, very, very quickly, because I'm running out of time. Ketamine actually blocks an NMDA receptor, which results in increase in release of glutamate from the presynaptic, actually from the astrocytes, and that increase in glutamate release actually is available to act on other glutamate receptors. One of them is AMPA, and the activation of AMPA is actually one of the basic mechanism which actually results in increased secretion of brain-derived neurotrophic factor, which eventually is been shown in research to result in antidepressant effects. So these were some of the early studies. I'm going to pass through them. STAR-D is one of the most well-known effectiveness trial funded by the NIMH, and this actually effectiveness trial was a multi-center, very expensive study. And actually, the remission rate in this after 4 stages of treatment was only about 1 out of 3 patients, which is not good. But when you look at S-ketamine and ketamine, I'll show you some data later. But the question before we discuss a little bit more about the intranasal ketamine, S-ketamine, is that why S-ketamine? Why not R-ketamine, which is the another enantiomer of ketamine? The reason is, as you can see in the slide, that S-ketamine is 3 to 4 times more potent than R-ketamine. So that's a very simple reason. And then the drug intranasal ketamine approved in S-ketamine approved in America is called Spravato, and that is the label for that. and it is actually delivered. It delivers this spray delivers two sprays of 28 milligram each, and the dose is that you have to use these sprays 2 times per week for 4 weeks, and the maintenance is once a week or once every 2 weeks, depending upon the response. And the dosages are available are 56 milligram, which has two devices. I just told you about that, and then 84 milligram, which is three devices. 20 milligram, 28 milligram was not shown to be effective. So I'm going to bypass the evidence from the clinical trials, but I just wanted to show you that. So these are two slides which are side by side. One is the phase 2 dose response intranasal esketamine graph, and the other one is the phase 2 study with IV esketamine. So one is intranasal, and on the right side is the IV. If you look at the difference, the left side actually cannot be compared fairly to the right side, because the left side is a fixed dose study, which means that different groups receive different dosages as well as a placebo. On the right side, it was also a fixed dose, but it was given IV in only two dosages, 0.2 milligram per kilogram and 0.4 milligram per kilogram. So you can see that on the left side, when intranasal esketamine was used, you can see the higher dosages actually, the higher dose of 84 milligram actually result in most significant effects. Whereas on the right side, when you see IV esketamine, you see that there is hardly any difference between 0.2 milligram per kilogram and 0.4 milligram per kilogram dosages. But if you look at the response, you will see that that the IV esketamine maybe numerically was slightly better than the intranasal ketamine, which is, of course, IV probably is a little bit more in higher dosages available to the site of action, which is the brain. I'm going to skip quickly over this because I think we are getting almost to the time. But I really wanted to spend a lot of time on ketamine, which I had to cut on some slides as well. But vertioxetine, very quickly. The reason vertioxetine is one of very unique antidepressant is because vertioxetine is the first drug to be approved by the FDA for improving a specific cognitive function in depressed patients. The other antidepressants have not shown such a good effect on cognition, not all the cognitive measures, but I'll tell you which one, as shown by this slide. This was the preclinical trial in which vertioxetine was assessed. The cognitive effects of vertioxetine was assessed using the digit symbol substitution test, and you can clearly see. But let me tell you what DSST, digit symbol substitution test, assesses. It actually assesses the processing speed, meaning attention and concentration. So it's actually a very important cognitive function. It does not test other cognitive functions such as executive functions or other working memories or visual or verbal memories. But you can see that the best effects of vertioxetine as compared to the placebo, on the extreme right side, you will see in professional people who took vertioxetine for the treatment of their depression, actually showed the best effects of vertioxetine on this aspect of cognitive function. Working population was in the middle. All patients is still separated from placebo, so that is why FDA approved it for this improvement of this specific cognitive function. Levomilnacipran is a unique SNRI. It is the only SNRI which has more effect on epinephrine system than the serotonin system. And that has some clinical implications which I cannot address at this time. Aristada Initio, which is one of the delivery, very unique and exciting delivery system, aripiprazole, long-acting injectable, actually uh, is kind of a breakthrough because when you start this injection with some oral dose and an initio, which is only one time used when you start the Aristada long-acting injectable, you can actually develop therapeutic levels starting next day. And it's really good for the patients who are discharged from the hospital, so that you know that if you use this product, um, uh, the at least in terms of plasma levels, you are covered, and there is no risk of falling through the cracks for the patient for the lack of for medication non-adherence or developing plasma levels to the effective degree. So this is really an exciting long-acting injectable. It is quite expensive, but it is becoming quite popular here in America. I cannot go into the details. Viloxazine is the new drug, non-stimulant drug used for ADHD. Novel indications, pimavanserin is, as I discussed earlier, so I will pass that. Valbenazine is the drug for tardive dyskinesia, and deutetrabenazine is also another one, the second one. Filibanserin for the hypoactive sexual disorder in females. Brexanolone is a very exciting molecule, as I told earlier. It is approved for the treatment of postpartum depression. It is the first drug which has an effect on the GABA system, and it is approved for a type of depression. So the GABA system is also coming to be one of the more significant of the many systems which we know are associated with depression, is another coming up as one of the very interesting system underlying depression, especially the postpartum and the psychotic depression. And this is a GABAergic agent, brexanolone. It is non-addictive though, completely non-addictive. Okay, so I think I will finish my presentation here because we are right at 30 minutes. I hope I went through my slides very quickly, but I hope it gives you some insights into some of the new exciting developments in psychopharmacology. I really wanted to come to Lahore, but it seems like that the airlines are keep on extending my dates and canceling my flight, so I won't be able to come. But inshallah, hopefully in future, when we have similar presentations, I can maybe do a workshop on these agents and some other aspects of psychopharmacology. Thank you, and I hope I was able to make some sense out of all these very complex developments. Thank you.